Good morning, everyone, and welcome to Meds Ed. I'm Paul Carson, and I'll be your host and co-presenter for the program that you will be enjoying this morning. Meds Ed is an ongoing education program that's sponsored by CareOregon's pharmacy departments, and the focus today is on basics of motivational interviewing, taking a look at that through what we call a trauma-informed lens. So I'm going to take you through a little bit of housekeeping, including our agenda this morning, and then we'll go ahead and get started. It's great to have you all here. We're going to start off in our first segment today, giving kind of an introductory perspective to the idea of how trauma impacts health later in life. A lot of folks who work in the CareOregon network, this is old hat and folks know this already, but this session here today was designed for folks who this may be a new concept for. Perhaps you're not as well versed on the idea of how trauma affects our health. So this is going to be a very introductory level overview of trauma, and then we're going to gradually segue into something called medication trauma. And you may be thinking, well, medications, what's traumatic about that? And we're going to explain how there's actually quite a bit of trauma that impacts the patients that we all deal with. That's a term that we now refer to with that, medication trauma. We'll take a short break at 9, and then we'll do a second hour that focuses on the fundamental basics of motivational interviewing. A lot of folks have already had some MI training in their past, but it's one of those things it's good to keep refreshed from time to time, or maybe look at it with a new perspective. And so that's what we'll be doing here today. So very simple kind of ground level content for you. If you have no experience with the idea of trauma-informed care or motivational interviewing, you're going to be very happy that you're here because you're going to get good exposure to those things. After our second break around a little bit past 10, between 10 and 10:15, we have Sharon Allen, who's a community-based mental health therapist who practices MI a lot out in the world. And she's going to be giving you some practical examples and stories of how MI has helped to make a difference for folks. And then towards the end of our program this morning, the two of us will be getting together and we'll be responding to your questions that have come through this morning and doing kind of a panel presentation where we do a little Q&A. So that's kind of the lay of the land that we've assembled for you this morning. I think you'll enjoy it. Now, for those of you who are just here for the CME, I'm looking at you, Dr. Jones, but we do have continuing ed credits available, as we typically do for most of our Meds Ed programs. You'll see here that we're sponsoring our CME through the American Academy of Family Physicians. Good news is for you pharmacists, the Oregon Board of Pharmacy recognizes that same physician's CME credit towards license renewal hours as well. So they're equivalent hours, no problem there. At the end of the session today, I'll be sending out a survey to everybody who enrolled for this class that you just go through. You put your name down on the survey, you answer a couple of very brief questions to do a self-assessment, and then we'll subsequently mail you your CME certificates. Same deal for folks who are LCSWs, except you have a different survey that's specifically tailored for that designation. I'll give you more information about that at the very end. So sit tight and we'll get all that taken care of here today. Here are the learning objectives that we'll be focusing on as we cover the content here today. At the end of our session this morning, you will be able to understand the relationship between traumatic experiences in life and overall health. You will understand the concept of this idea of medication trauma and how it really can have a strong and profound impact on patient engagement. And you'll be able to summarize how motivational interviewing is an extremely effective communication tool for patients who experience a background of trauma. So that's what we'll be coming away with and focusing on here today. The first segment that we're going to do here today, as I mentioned, overall, this is motivational interviewing basics. But initially what we want to do is we're going to cast our eyes on this idea of trauma and what trauma does. Let's begin with a little background, because I know we have a lot of folks on the webinar here today from beyond the Oregon area. I think most folks are part of the CareOregon network through our network of 3 different community care organizations, coordinated care organizations. There's HealthShare that monitors the Portland metro region in Oregon. On the coast, we have Columbia Pacific CCO. And then down in the southern part of the state near the California border, it's Jackson Care Connect. So those are the three CCO environments that we have members in. CareOregon's been founded since 1993, and we have well over 300,000 members that we take care of. Our members are fairly challenging members, all right? So we have the lion's share of our folks have Medicaid coverage. A smaller group of patients also have Medicare, but most of those who have Medicare are what we call duals, where they have both Medicaid and Medicare. So a extremely vulnerable population for the most part. There's a lot of challenges for us. Our purpose at CareOregon is to make sure that we are able to provide health and well-being for those folks, regardless of income or whatever their social circumstances might be. And there are a lot of challenges, social determinants of health that impact the lion's share of our members. Here's just a handful of the factors that folks tend to deal with. We have a lot of members who experience homelessness, who are living below the poverty level. You're going to see a lot of our members who have quite a few different chronic disease comorbidities, a lot of substance use disorder, quite a lot of behavioral health concerns, folks with disabilities, not only low health literacy, but low literacy in general. It's a challenging population to provide care for, and it's a unique group of individuals that really are trying to get a handle on improving their lives, which is why motivational interviewing is such an important aspect of being able to interact with these folks. So let's begin with our focus on trauma now that we've set the stage on who is impacted by it in our care. When we talk about trauma, we're not using the definition of trauma from an emergency room setting, anything like that. We're talking about events that happen to folks that are extremely upsetting to them and, at least temporarily, are going to overwhelm their ability to cope and their internal resources. That's the Oregon Department of Justice definition. I think it's a really good one that we tend to go by quite a bit. We have to remember that when we're interacting with patients and folks in general, but in particular, when we're looking at the patients that we have contact with, we're only getting to see the cover of that book. We see a tiny segment of what's really going on with those folks. What's really happening beyond what we see in those interactions is far deeper and more profound than we can always necessarily recognize at first. So there's a lot going on, and we have to remember that when we're having those interactions. In terms of the things that influence someone's overall health, we talk about social determinants of health as a concept, right? In terms of the healthcare universe and what we can do to impact an individual's well-being and health, if you look at this graph here, you look at the bottom, only about 20% of what we're able to do for folks actually influences their health. We're like 1/5 of the variables that are colliding upon those people there in their access to the healthcare environment. A lot more influential in their overall health and well-being are the behaviors they engage in. Do they use alcohol and drugs? Do they exercise? Do they smoke? The physical environment that they live in, and then all those socioeconomic factors, like do they have a support network of family and friends? What's their income like? Do they live in a safe environment? Their education level, and then on top of that, do they experience discrimination on a routine, everyday basis? Those are the factors that really, we're talking 80% of the factors that influence someone's overall health beyond what we can do as healthcare. So you can see it's a challenging dynamic. The playing field isn't exactly level. And over half of those things can be traced back to the zip code you reside in. So it's a little challenging, but it's important to acknowledge the way that works. When we talk about trauma, we split trauma up into two types of categories. So there's public trauma. These are the things that are more occur out to a large number of folks at one time. If you've been paying attention to what's been happening on the West Coast here over the last few months of the summer and fall, we had some tremendous forest fires that happened in California and Oregon. That's the kind of public natural disaster that creates tremendous amount of trauma people who've been in a wartime environments or riots or any kind of natural disasters, earthquake, 9/11, things of that nature. Those are public types of trauma. Then we have on the other side, personal, more private types of trauma that are important to acknowledge because those are extremely individualized. There's personal violence, there is sexual assault and abuse, domestic violence. And when you look at those two types of trauma that can impact somebody, what we tend to see is that second category of the more interpersonal types of violence tends to be a lot more damaging than the natural disaster type of scenario. Just because if you're in an earthquake or you're in a place like 9/11, you can think to yourself, well, I just happened to be in the wrong place at the wrong time, or it was an act of God, if you want to call it that, whatever it might be, right? Bad luck. And you can deal with it on that basis. But when somebody's inflicting personal abuse and personal trauma on you, it feels a lot more deliberate and a lot more intentional, okay, as opposed to an accident of nature, because it seems like somebody set out to do that to you on purpose. And that's very damaging, especially to our sense of ability to trust in other people. One of our medical directors at CareOregon has introduced this concept that's really, really helpful. When someone's coming in to see them for the first time, a lot of the coaching they will give to other clinicians and folks in their practice is, if this person's coming in, where do they land on what's called the trauma triangle? It's a way of basically trying to identify which of these types of trauma do we think that they have been most impacted by. I'm not going to go through this in great detail, but just to give you an idea of where those kind of core types of trauma are, right? Is it more of an anxiety type of trauma where somebody's constantly re-experiencing things in dreams or visions that they're having, where memories of bad things that happened before are getting triggered a lot? Is it more akin to like PTSD, that kind of thing, where you're very easy to startle, you're feeling very jumpy, it's easy to feel nervous and unsettled and unsafe? Or are we feeling depression, where there's a kind of a disconnected feeling of not being part of things on a regular basis, feeling numb, having a difficult time connecting to activities and relationships? So anxiety, PTSD, depression make up that idea of a trauma triangle. Can be useful reference points in terms of trying to get a sense of where someone's at in their journey, so you can figure out how to best approach them. All this leads us to the idea, and you look at the data here, it's really not a very old concept, though I think in our line of work, and especially in CareOregon, we tend to think that this is something everyone's well grounded in, but when you chat, not everyone necessarily is when you go out and speak to people in other parts of the country. But trauma informed care is a mindset and a method of approach, understanding this impact of trauma, that it's physical, psychological, emotion, and that we want to be able to interact with patients in a way that helps them rebuild a sense of control over their lives, of safety and empowerment. So you will hear this phrase, trauma-informed care, a great deal, and that's a lot of what we want to be able to create more of in the environments where we interact with our members, because they've been through a lot. It also has started to influence our language in terms of the words we choose to use. Okay, you will find we very seldom like to say addict anymore, and this is the examples I'm using here are more from a substance use disorder lens, because the words we use can really influence and maintain stigma for folks who had a background of trauma. So using trauma-informed language is really important. Just a quick example of this. Up until very recently, you would still hear the word relapse quite a bit. And relapse is, I think, just as harmful as addict in some ways, or substance abuser. Now you hear recurrence of use more often than relapse. So it's just that way we're evolving the language to be more mindful of the experiences folks have, because language can be a trigger all of its own. And so it's important to know that some words you use can be harmful to others and can end up triggering aspects of trauma that we never intended to. So the mindset that we're trying to maintain and sustain with trauma-informed care is a shift of the way we look at people. Instead of looking at folks with this lens where we're going, wow, what's wrong with you? Pretty judgmental assessment, like there's something aberrant with that individual. Instead of taking that stance when we ask questions, when we're looking at an individual, instead we try to say, what happened to you? What were the events that you experienced in your past that set you on this course where you're experiencing what you are now? So that's the change. We want to be asking a different question with trauma-informed care. What happened to you and how can we help? Because there's all different kinds of trauma that we can experience and all types of experiences that can color the rest of our trajectory in life. Now, there can be the trauma that we feel that if you're driving down the road and you see the flashing lights in the rear view mirror, and even if you've done nothing wrong, the sense, oh, I'm going to be pulled over, I must be in trouble. Something happens physiologically to us when we see that in terms of how we respond. If you were living in a country where there was tremendous oppression against you because of your background or ethnicity or because of you being in a wartime environment, you suffered a lot of traumatic situations in that kind of scenario, that's another kind of trauma as well. And like we mentioned earlier, we're talking about social determinants of health. Imagine if you, instead of just, the normal sense of, oh, a police car is pulling me over. If you're a person of color and every time that you see police lights in the background pulling you over, you're not just worried you're in trouble, you're worried there's a chance you just might die as a result of this interaction. That kind of exposure gives you a sense of absolute peril. That's a whole different level of trauma than many of us can relate to, but it's something that folks of color are having to deal with on a daily basis all the time. So I think it's extremely important to acknowledge those things. That's traumatic, to be carrying that through life on a daily basis. What are we talking about in terms of the physiological responses? Well, we know that you can feel tense, your heart rate is going to increase, you're maybe getting sweaty palms. Those are the kind of things that we typically recognize as being traumatic responses. Your blood pressure starts to go up. Probably really difficult to think straight and focus if you're having thoughts of peril and impending doom that are coloring your interaction, right? Because we know now that trauma not only impacts the brain, it can reshape the brain as well. I mean, responses that you can have where you are re-experiencing something that happened in your dreams, or intrusive images that are, pushing their way into conscious life because something reminds you of those. It's terrible when somebody feels withdrawn and they're unable to connect with others, and there's that isolation that occurs there because they're trying so hard to avoid things that trigger those traumatic memories. These are the kind of things we have to be mindful of when we see folks behaving in a certain way. It's out of their hands because it's something that happened to them and changed the fundamental configuration of the way their brains are put together. I'm not going to get all neurological with you guys here for this this section here, but just, you can see there's things that happen in the brain, okay, in terms of way from the hippocampus to the hypothalamus to the amygdala. Okay, the amygdala, there's a lot going on in that area there where that fight or flight response to danger occurs. And if you've got thoughts of peril or danger that are happening in there, there's just all kinds of changes that have occurred in our brains. And it's bad enough if you're an adult, okay, and you've been going through life and you have some kind of trauma like that. But where things really start to become dramatically impactful is when the brain is still developing. Okay, what you see going on here, these are PET scans on the left of a normal brain of a child, okay, their brain is still developing, versus on the right, an orphan who had been institutionalized after a lot of deprivation in their infancy. And you can see that those areas of the brain that are incredibly important when our brains are still developing as children. The part that helps you learn or concentrate, the prefrontal cortex. Your amygdala, you need to be able to feel safe, feel calm, be able to sleep normally. And the part of our brain that helps us regulate our emotions. That's a difficult thing to deal with when you're a child on best case situation. But if those important developmental areas and landscapes of the brain have been traumatized because of experiences you've gone through, look at the result of that. Your brain's wiring has been taken apart, and it's very, very difficult to recover from that. It's certainly going to impact your behavior as you try to make your way through life. The reason we mention this is because a lot of the groundwork of trauma-informed care and a lot of the research study that has most drawn awareness to this as being something that has a profound depth of influence to health is something called the ACE study. You go ahead and, if you don't mind, just interact in the chat. Folks, you can let us know if you heard of the ACE study before, or is this totally new to you? I'm always very curious to hear folks who don't know about the ACE study. I was talking to a room full of neurologists a couple of years ago, and I asked them, who's heard of the ACE study? And I was very surprised to hear that very few people had. It's not as widely known as we'd like to think it is. But when we talk about the ACE study, ACE is Adverse Childhood Experiences, the ACE study. This is done in the late 90s by a physician, Dr. Vincent Felitti, okay, through Kaiser Permanente. Okay, he had a group of 17,000 Kaiser members that they used this study on. Okay, and the idea was to take a look at how stressful, traumatic childhood experiences that you had later impacted your adult health, okay, to establish what the connections are between maltreatment you experiencing and your well-being later in life. And that these experiences actually have a huge influence on the causes of physical illness and poor quality of life that folks experience as they age. The results were frankly shocking because we found out that trauma is far more previously indicative than we ever imagined, as you will see. Now, I want to point out real quickly, okay, when we're looking at this study of 17,000 folks that are in the ACE study, this is not a population like we're talking about with CareOregon, where it's largely Medicaid, with all those social determinants of health. This is a broad cross-section of just typical KP membership, okay? So not necessarily everyone is experiencing poverty or substance use disorder. This is just a wide, broad spectrum of the population as a whole, which is why this is so impactful. So imagine how much worse it would be for folks who do come from the backgrounds that a lot of our members have. Here's basically what the ACE study looks like. It's less than a dozen questions. Yeah, I just want to take a second, have you read those over, but this will give you an eye of the kinds of questions they're asking folks to look back and consider on when they were in their youth. Was someone a problem drinker, an alcoholic? Did you live with somebody who served time in prison? Were your parents together? Was there physical violence in the household? Were you ever experiencing physical violence? Were there any kinds of abuse that you felt, be they physical abuse or emotional abuse or sexual abuse? But uncomfortable questions, asking people to think back on things that they haven't maybe looked at for many years consciously. But that's the questions that make up the ACE study. Okay, and so if you're looking at that, those questions are basically taking up those kinds of trauma and splitting them up into three different sections, all right? There's abuse, be it physical, emotional, or sexual. There's neglect, which is just as damaging. And then there's the dysfunction in the household, an incarcerated relative, seeing your mom being treated violently, substance abuse going on, behavioral health issues in the household. All of these are the types of trauma that they're looking to identify. Filitti's own words: We found a strong graded relationship between the breadth of exposure to abuse or household dysfunction during childhood and multiple risk factors for several of the leading causes of death in adults. Take a look at some of these numbers. Over 60% of participants had at least one category of childhood trauma. Over 20% experienced 3 or more categories of trauma. 28%, almost a third, experienced some kind of physical abuse. So let's say there's 100 of us on this webinar here today, okay? And 1/5 of us, that's 20 folks who've experienced 3 or more categories of trauma statistically. It's sobering to think about. And the more categories of trauma experiences in childhood, the greater the likelihood of these type of health conditions finding their way into your life. Suicidal ideation, unintended pregnancies, smoking, chronic disease, heart disease, illicit drug use, alcoholism, depression, and then risk for intimate partner violence. It's hard stuff to talk about, but the study revealed that it's just way more prevalent than we ever dared imagine. And statistically, the children who experience trauma are 46 times more likely to develop a substance use disorder as an adult. So I think it's helpful to hang on to a statistic like that, because when you see an individual who's coping with substance use disorder, it's so easy in our society to make snap judgments about those people. We tend to see it happen time and time again, but let's remind ourselves that if that's the situation, what's statistically likely to have happened to that person to cause that? 46 times more likely is a dramatic number. This is just illustration showing adverse childhood experiences, those social and impairments that lead to, unfortunately, the adoption of health risk behaviors, high risk behaviors of one kind or another. If you take those kind of behaviors on, odds are it's going to lead to disability, problems with you functioning in society, certainly chronic disease, and then untimely early death. That's the pyramid that folks are trying to get out of, leading from conception to death. So that's basically the way the ACE study illustrates itself, as a pyramid. But the key categories that we're talking about, how folks are finding themselves impacted here, it's really, I keep going back to the word profound, because I think it's one of the strongest words you can indicate in terms of how far-reaching these impacts are. All the chronic disease things that we're looking at, and we see so much chronic disease among our member population in CareOregon, diabetes, depression, heart disease, high blood pressure, cancer, COPD, all of those chronic comorbidities that we see, behaviors of drug use, smoking, alcoholism, and then in general, it's how do you measure life potential? But that's what we're talking about, right? We're talking about ability to achieve academically, time missed from work, graduation rates. All of those factors there have a huge relationship to the risk for well-being that those kinds of trauma impact. So if the hour we're spending on this topic here today does nothing else, hopefully it's at least reminding us that there's a lot of neglect that goes on there, a lot of emotional abuse, and hopefully it reminds us all to have more empathy for our fellow human beings. This slide here is an alias slide of a CareOregon member that we're just going to call Miranda for anonymity's sake here. But Miranda shared a lot of the details of her trajectory in life, and we put this together to illustrate, I think, pretty dramatically an example of what a traumatic childhood can be like in terms of how it influences your life later on. To me, this is almost a perfect example of where you're at in looking at an average ACE study situation. Less than 50 years old. Okay, Miranda has like 6 children. Okay, she never graduated high school. She's in recovery from substance use disorder. Uh, Take a look at from birth to just age 5. Okay, unstable housing as a child, as a baby growing up. By the time she's 5, her parents split. Okay, she's lived in all these different caregivers, a lot of unstable, potentially unsafe environments growing up. 11, moves back in with mom and endures daily sexual abuse from her stepfather. Okay, by the time she's age 15, she's had her first pregnancy and gives birth, and her stepbrother is the father. Not surprisingly, she drops out of school shortly thereafter with a child to take care of. By the time she's 18, she's had 3 children. She's still living in an abusive environment. And at this point, she's not only using drugs on a regular basis, but she's also selling, trying to make a living doing that. Um, by the time she's 21, within a couple of years, of course, not surprisingly, she's going to prison on drug charges there. Um, Imagine what those years are like between age 21 and age 27 before she attempted to commit suicide for the first time. She's had 3 more children born after that, and she's had heavy alcohol use, a lot of drug relapses, cancer diagnosis, and a series of car accidents as well. She's had multiple surgeries. She no longer has any teeth. She has no dentures, and she's on multiple behavioral health medications. And she felt like she could share her story with us because there's not just one Miranda out there. Unfortunately, there are hundreds, if not thousands, in our member population. So, this to me, it's a vivid picture. It's a life that didn't have to go that way, and it's what we're always trying to do in our interactions with our members is how do you help somebody that's gone through something like that? What can we do? How can we, with our 20% of influence, how can we help? How can we try to make Miranda's life better? Because on interactions with physicians, with clinicians, when you're been in an unsafe environment and you're suddenly having to go in to a professional environment to get help, it feels like there's a huge power differential. Like you're not on a even playing field at all. You feel a little outgunned because there you are, you're going into the person's office. And is it one of those medical offices where there's a lot of diplomas and certifications up on the wall, and you kind of just feel, wow, a little outnumbered here. Like maybe I don't belong. And especially if somebody's asking, looking at you from the old school perspective of what's wrong with you, instead of what happened to you through trauma-informed language and trauma-informed care. So what we're trying to do with trauma-informed care and with motivational interviewing is we want to change that power differential. We want to be able to make our patients feel like they're more on a level playing field, where they're able to actually feel like, their perspective matters. And perhaps most importantly, that we understand them and that we have empathy for them and we understand what they've been going through. Because that's incredibly important if we want to have any kind of rapport and be able to help influence folks and guide them towards more positive outcomes. What we'd like to do next is focus on a different kind of trauma called medication trauma. This is one that you may not have heard of here before, but ask yourself, everybody just right now. I mean, and you can, if you feel like it, you can certainly put your answers in the chat, but just consider it for yourself. Ask yourself, how many medications are you on right now? It's rare to find somebody who's not on anything, okay? But how many medications are you on right now? Or you can ask yourself this question. Do I know somebody in my immediate circle, a loved one, family member, spouse, what have you, that has had some kind of a intense relationship, intense upheaval as a result of their relationship with medications? Whether they've had something with the medications that didn't go well, or that caused some kind of damage for them. something where medications could have been handled better. Just consider for a second as we move into this segment. Because friends, it's one of the most confusing realms I know of, is medications. We have, I guarantee you these numbers are not current, well over 12,000 members in our population who've had more than 16 or more medication changes in the course of a typical year. In my work, sometimes I will prepare medication lists and get them to care providers or clinicians so they can see uh, currently what all the different meds are that a member's on. Medication list I prepared last year had 37 different active medications on it. 37 for one person. And if you're responsible for navigating taking all of your own medications by yourself, and you see that packaging is not exactly helping that situation, you can see it would be very easy to confuse things. Remember, we're talking about a population where literacy and health literacy is very low. And marketing and the way those are packaged, that's not doing us any favors just out of the gate. All right, so I'm going to surprise you folks with a pop quiz at this point, and please type your answers in the chat. Some of you may know the answer to this, but I'm guessing a lot of you do not. Pop quiz friends, what's almost never written out on a medication label? I'm hearing the Jeopardy music in my mind here right now. I don't know if anyone else is, but what do you almost never see on there? We make a lot of assumptions in healthcare all the time, and I think a lot of people definitely assume on this one. I'm seeing some interesting responses come through in the chat. I think a couple of people have gotten it. That's good. That's good. Dosage. Okay. All right. What's the answer? All right. Well, what's almost never written on a medication label? What it's for, its purpose, the core disease state that that medication is supposed to be helping with. It very seldom spells out for your depression, for your hepatitis, for your hypertension. Now, medications can be aligned to more than one indication, and every now and then you'll run into a really diligent pharmacist who will make a real specific purpose of making sure that that indication is spelled out on the label for those folks. But remember, there's HIPAA, all right, which, you know, good intentions being what they will. If you're on 15 different medications and none of them say what they're for, is that potentially a recipe for a problem? Gee, I don't know why Mrs. Johnson keeps confusing her pain medication with her heart medication. I don't know why she keeps taking the one thinking it's the other. Could it be perhaps that all these pain medications have like 7 different syllables, most of which are made up of consonants? I don't know. You tell me. But it seems like there's a problem and she's confusing them on a regular basis. That's what we run into. And to add to that, you have other different variables as well, where you have several different prescribers, all with good intentions, coming together to try to add to that mix. I'm sure if you think about your own medication list when you have it reviewed when you go into the doctor's office, right? Very seldom, it's a lot easier to put a medication on your list than to have it removed successfully. I think that's one thing that we've definitely learned in our work experience with prescriptions. And folks don't always know if it's working. They're not sure. They don't really know how to have the conversation. And especially when there's a lot of different prescribers and physicians involved, the EMRs aren't always super transparent where everyone can see what everyone else is prescribing. And so a complete medication list is sometimes like a unicorn for folks to try to figure out what's going on. But most important, a lot of times people, especially when there's a lot of medications, like you see that woman with right there, they don't know why they're taking each one. They've forgotten, or they've forgotten what the purpose is for that particular medication. And so it doesn't seem like a really good recipe for success when we acknowledge it. And that's a lot of what my job is in terms of the reminders I try to push out, is see things from the perspective of the members, not our own assumptive perceptions that we have. Right? Think of it from their perceptions. Yeah, that's confusing. It's a wonder that they do ever regularly remember to take the right medication. So what we're describing here has been identified, and I think identified extremely well by Jim Slater. Jim Slater is the VP of the pharmacy department at CareOregon, and I think that a lot of us think of him as the conscience of the pharmacy department at CareOregon. But Jim came up with this concept and identified what he calls medication trauma. And this is the definition out here. It's complexity and the lack of coordination that occurs and overwhelms both the patient, everybody's resources who are trying to look after that patient, creating an outcome of fear, many errors, and it leads, shockingly, to bad adherence and poor health outcomes. Medication trauma. Now, in other parts of the country, you may not be hearing this phrase that often yet, though we're doing everything we can to get it out there, where folks become more familiar with it and socialize this concept so that it's more widely recognized, because it needs to be more widely recognized. So when we go out to conferences and present in different places and outside of Oregon, we try to make sure folks get hip to this concept and encourage them to share it with others, because it's definitely happening. Odds are it's happening to people you know. It's definitely happening to a large percentage of CareOregon members, without question. So medication trauma, basically we illustrate it like this. At the top of the wheel, we see our typical members, right? We know that our typical members have a background of trauma that they come from, all right? So they've got trauma, they've got impairment that goes on. We've seen how that impacts the brain, how that causes chaos for folks, especially when it's been something that's happened in their childhood, leads them to adopt risky behaviors, eating too many donuts being the most innocent of those risky behaviors, because we know typically they manifest a lot more perilous means. Their diseases get worse, their comorbidities amplify, and what do? Because it's America. We throw medications at them, right? We prescribe. And so we have lots and lots of medications that we throw in those comorbidities. And then we get to a point very often where we are actually prescribing medications to counter the side effects of those first medications. Oh, that one caused this bad side effect for you. Well, let's have you take this to help mitigate that side effect. So pretty soon you've got the plastic shopping bag full of medications, and you're trailing metformin behind you like a trail of breadcrumbs going on there. And that's not uncommon. And so when you've got that situation going on and you've got that kind of a heavy medication burden in your life, the premise is that that is its own level of trauma on top of everything else you're experiencing. And it just perpetuates another round of cyclical trauma in your life, medication trauma. And it's a whole lot worse when you've got two cycles of trauma in your life than just one. So what we want to make sure that we do with our work in the pharmacy department is we want to make sure that those medications are serving a purpose, that they're earning their way in. I think that's important. You can't just reflexively prescribe. Those medications need to have to just a purpose in there. And if there's a way we can get folks off of unnecessary medications, it helps to find those ways and to look at those possibilities for folks, because you can see the potential for them to do more harm than good. Okay, medications should be a source of hope and healing for individuals, not a source of trauma. Each one of those meds needs to be able to earn its way in and justify its presence. That's what medication trauma work is all about, and a lot of what the kind of solutions we develop in the pharmacy department have been aimed towards. A couple things. We found in talking to our members and clinicians and caregivers, when it comes to medications, they don't get discussed very often with folks. Yet I'll tell you a secret, statistically, okay, in terms of member-patient interactions with clinicians, a typical patient will see their pharmacist 5 times more often in the course of a given year than they do their PCP. So they feel they have a little bit more of a relationship, at least familiarity with their pharmacist than they do with their regular clinician or provider. And so sometimes they'll confide things to their pharmacist. They won't necessarily say it to everyone else because they're afraid of looking like a failure or feeling that they were judged. And that taught us pretty quickly that, folks want to talk about their medications. They just didn't know that they had an opportunity to. They want to be heard. And that notion is going to echo very loudly into our discussion of motivational interviewing in our next segment. But people want to be heard. They want to be understood, especially if your trajectory in life has been such that you feel like you have been dismissed time and time again, and that people haven't taken you seriously because of your social circumstances. People want to be acknowledged. They want to be heard. They need to feel that they matter, especially if we want to do something crazy like get their medication adherence to improve. We're going to have a lot better shot of doing that if we're able to let them feel that we get them and that what they have to say about their medications matters. So a couple solutions that we've worked on. One of them you may have heard before in CareOregon is called the meds chart. So take a look at this and you'll see a populated meds chart with a handful of the typical prescriptions you might see for a member. The way the chart works is basically, it's a medication list, but it's actually more than that. It's kind of a catalyst, right? It's an interview tool that a pharmacist who's doing a medication review, clinician or a care provider can use to talk with their member, with their patient, and try to find out what's really going on with their medications and get them to open up and elicit some conversation about their medications. So it's kind of a stealth tool. It looks like a medication list, but what it's really trying to do is it's trying to coax a conversation into being about medications. So how does a chart work? We would pre-populate a meds chart electronically, like a fillable PDF, with all of those different medications from the claims database. And then we have that colorful Likert scale there, smiley, friendly faces, green, happy association, neutral, or a frowny face reaction. And if someone's marked a red frowny face next to one of their medications, it's a sign that there's a problem. They have a negative association with that medications. And when we first started piloting the chart with folks and using it in these interviews at clinics, sometimes you'd hear folks say, wow, no one's ever really asked me how I feel about my medications before. But it turns out if you ask folks that questions, they have a lot to say. They have been wanting to have this discussion. No one's just asked them before. So we encourage use of the chart as much as possible, because if they've marked that kind of negative indication, probably they're having a side effect they don't like, right? And we need to see what our other options might be, because given who our typical members might be, if there's a negative thing happening as a result of taking those medications, a side effect, well, what do you suppose they do? They probably just stop taking it, right? It doesn't occur to a lot of people that, wow, this hypertension medication made me feel real bad. Maybe there's another one I could find that doesn't make me feel that way, that's just a little bit different. It doesn't occur to folks. They just assume all hypertension medications must have that same side effect. And so they just stop taking it. Or as happens frequently among our members, they'll give it to a buddy who has some similar thing like that. Here, you try it. It didn't work for me. Maybe it'll work for you. And medications get tossed out amongst the community that way, where it's kind of a pure roulette. You don't know what's going on. So having these conversations is really, really important. Why do we want to do that? Well, we want to be able to help identify side effects, but we also want to be able to uncover potentially threatening, dangerous medication errors that are in the lives of our members. Here's a typical example right here of how the chart might look when it's filled out. This individual here likes their anxiety medication because it makes them feel a lot calmer. But there's some side effects for these other meds that they're not real happy about. They don't like feeling sleepy because they have to look after their grandchildren as a partial care provider. They don't like that nervous, itchy feeling that the hypertension meds are giving them. So it's good to be able to identify these things, because as we saw earlier, with a lot of different prescribers working together and adding to that medication burden list, the potential for things to go south is high. And every now and then, somebody will have something on their medication list that just shouldn't be there. It should have been removed from their medication list when they were discharged from the hospital, or there's something they should be taking that they're not taking. The claims database is not going to tell you these things. It's just not. It'll show that somebody refilled their prescriptions, but about the only way to really find out what's really going on is, wow, have a conversation. Let's talk with that patient about what they're experiencing and what's going on with them in their medication universe. And ideally, let's talk to them in a way that encompasses trauma-informed care and a style of communication that really shows that they're in control of their life as seldom as they may feel that they are, which points the weather vane towards where we're going to go next with motivational interviewing. So that's what we try to do with things like the chart, is we want to find out what's really going on, because I think we know every year people end up getting hospital admissions that are as a result of a medication problem or some error with their medications, where they took one thing thinking they were taking something else. I thought I was taking my heart medication. Turns out I was taking my pain medication. Or I took too much of one thing because I was confused about what to do because I was confused. Okay, that's an easy state of mind to relate to. And a medication-related hospital admission can be really dangerous. Sometimes people don't get over that. And so we want to be able to identify those things before they happen. And so having a conversation about medications becomes incredibly important. So I encourage folks all the time, if you're working with CareOregon members and you think that there's an issue going on with their medications, let's get a meds chart and try to see if we can have a pharmacist or somebody have a conversation with that individual about how things are going with their medications. It could save lives. It could certainly improve their overall well-being. Maybe we get some unnecessary medications off their med list, and we try to drive together towards better outcomes. So that's a lot of what we're trying to use tools like the meds chart for, right? We want to decrease hospital readmissions and trips to the emergency department. We want to improve medication adherence, but we want to make sure that we're helping reduce those errors that occur as well. We want to educate patients about the importance of taking their medications, so they understand the value of what it can do for their lives. And we want to empower people. That's a big deal, because if you don't have rapport and engagement and folks who are feeling to some degree more empowered about their lives, it is kind of silly to expect them to just magically improve their adherence to things just because we tell them that they should, right? It needs to be a relationship driving that, and some awareness that happens. And that's why we want to choose conversation styles that drive in that direction. Things like motivational interviewing that are helpful for folks who have that background of trauma. So meds chart's just one kind of tool. There's other things we've done as well. Real quick, we spent a lot of time talking about how the pill bottle stickers don't say what they're for, and folks who have challenges with literacy or who speak a different language other than English. How do we work around that? So here's something we tried out just as a experiment that worked really well. We came up with these visual icons, these stickers, right? Extremely cheap intervention to pull together, right? We just made stickers, but they have icons that pretty much regardless of reading level or language spoken, folks can identify. This is my heart medication versus pain medication. Mood for psychiatric medications, and then potential side effects like incontinence. What time of day to be reminded of to take this medication so you don't accidentally take it at nighttime as opposed to when you get up in the morning. So we will provide these medication stickers to folks, and they can put them on themselves or with their pharmacist or with their caregiver, and they just put it right on the label on there to reduce the chance of them misidentifying and potentially upsetting incorrect medication and causing all kinds of problems. So super simple intervention, really cheap to do, but it's the kind of work that we've been lucky enough to get encouraged to do in the pharmacy department of CareOregon that's really helped. It's a way of looking at things differently and trying to, most importantly, remember the perspective of the patient, right? Looking at their pill bottle, who can't pronounce any of these things. I know I can't for the most part. Take a look at a med list. I mean, my goodness, who's going to pronounce that stuff? I'm not talking to the pharmacists. I know all of you can, but a typical person is going to have a really hard time, let alone remembering what it's for. So things like these interventions that are really inexpensive can help. What we're trying to do with all of these things dealing with individuals in trauma is we want to be able to come up with a plan for folks that helps point them towards a more positive future, right? We're looking at that individual in the present. We're looking at their medication experience, right? Whatever that may be. What's the most important medication for you? Now, for some individuals, we might assume, oh, it's going to be their diabetes medication for sure. But then you ask them and they're like, no, for me, it's the anti-nightmare medication. That's the most important medication for me because I don't want to be reminded of my time living on the street when all those bad things happen. So even though you might think it's all those chronic disease meds, no, for me, my important medication is the one that stops my nightmares. So acknowledging that and seeing that person as an individual, we're able to really see them in the present, okay, and help them navigate all those life gaps that are going on and things they wish they could stop doing, things they wish they could start doing, because we're interacting with them in the presence when we're working on patient coordination, and we want them to have a positive experience amidst all that. We've all got stuff in our past, and we talked a lot about how things can be very often traumatic in the past. An overdose you had, childhood abuse, the death of a loved one. Those things can be really traumatic, right? But a lot of times as well, talking with folks, there's really good things that happened in someone's past, right? They used to paint, or they used to do gardening, or they had a job they found really satisfying at one point. They've lost that connection to those things in the present, but it doesn't mean that they can't strive and aspire towards reconnecting with those things in the future. They'd like to start painting again. They'd like to plant a garden. You know, they've gotten past that patch of hardness that they were in, and they're looking towards a more positive, goal-oriented future. That's where we want to be able to do. We want to help them get past that trauma. If there's something they want to stop doing, we want to help them stop doing those. Those can be just as most important goals as the more positive things. Let's stop taking 15 pills a day. How do we do that? I wish I could stop using. I wish I could stop feeling sad. Those are goals that we can help with, and we should help them together. Those are important care outcomes that we want to be able to always keep in our minds and help that person drive towards, so that the past is looking less dark. The present is looking like it's tilting more in the direction of a positive future. And that's where we want to get people towards. We want to help them heal, obviously, but we want to do it with a strong sense of hope more than anything else. So that concludes our initial segment for our first hour of the program here today. We're going to give everybody a quick break for about 10 minutes. So you can go check your email, take care of whatever you need to take care of, and then we'll come back here and we'll continue on this morning and take a look at the foundational aspects of motivational interviewing and how that can help with what we just discussed. So stay tuned. We'll see you in a couple minutes, friends. Thank you.